Hey guys, so we're back to review another study guide. I don't think I'm going to review the second study guide for the final, but I figured I should probably do this one because this one was at the start of the semester. So it's probably the one that people have forgotten about most of the material compared to the other two. So I think will be the one I review for the final. If I have time, I might get to the other one, but I don't think I will. So, okay, let's get right into it. Identify the most common cause of seizures. So, this is kind of a trick question. The most common cause of seizures is idiopathic, which means that the cause is not known. Explain the postictal phase of a tonic-clonic seizure. So, the postictal phase is after the seizure is done. The patient's going to be pretty obtunded, altered, sleepy. They might be alert to verbal or painful, but for a little while they're going to be drowsy. And this is actually the main way you can differentiate between syncope and a seizure if you don't witness the syncopal episode or the seizure. Because a syncopal episode will not have a postictal phase, but a seizure will, most of the time. Identify another name for a focal seizure and describe this type of seizure. So, a focal seizure is also known as a partial seizure. And this is going to have like very localized neurological findings. Explain status epilepticus seizure and why it is such a danger to the patient. So, status epilepticus is at least two seizures without return to consciousness, or I think any seizure lasting longer than 5 minutes also counts. Explain what happens during the tonic phase of a seizure. So the way I've remembered this is that the T in tonic, you think of tense. So they're tensed up, they're not moving. And then in the clonic phase, so explain what happens during the clonic phase of the seizure, that's when they're jerking, that's when the rhythmic jerking motion. So in T tonic phase, they're tense. Identify some of the treatments for a patient having a generalized seizure. So, treatment for a seizure patient is going to pretty much revolve around first of all, like airway protection, making sure they don't injure themselves, and then reversal of the seizure. So, whether that's giving a benzo or if we have found some reversible cause of a seizure like hypoglycemia, eclampsia, febrile seizure, trying to address those underlying causes. Identify what always needs protection during the postictal phase of the seizure. So that's going to be the patient's airway, because during the postictal phase, they're very obtunded. They're potentially not able to maintain their own airway. Identify the most common thing a layperson will want to do to a patient who is having a seizure. One of the reasons being the fear that the patient will swallow their tongue. So, yeah, you definitely want to prevent them from putting anything in the patient's mouth, especially their fingers. That's just not a good idea. Explain why a patient who just had a seizure should be placed in a lateral recumbent position. So, this is to help maintain their airway and prevent aspiration if they vomit. Explain febrile seizures. Okay, so febrile seizures are actually not caused by like a specific threshold of temperature. Like it's not about the exact temperature; it's about the change in temperature. And as your temperature increases, um, that affects the ion channels across cell membranes, which can lower the seizure threshold. So that's pretty much how that works. Identify a test you should always perform on a seizure patient that may identify a very easy action to stop the seizure. So I think this is probably talking about getting a blood sugar. Identify and list some controllable factors, risk factors for stroke. So controllable risk factors is going to be like smoking, alcohol intake, lifestyle, stuff like that. and uncontrolled blood pressure. Identify and list some uncontrollable risk factors for stroke. That's going to be like genetic, disposition, disability, stuff like that. Number one controllable risk factor for stroke, this is hypertension. And then explain why hypertension should not be decreased quickly in the event of a stroke and head injury. So in both stroke and head injury, you need to ensure that the brain is receiving adequate oxygenation. So any decrease in blood pressure, you risk the brain losing that oxygenation, especially if that person has chronic hypertension. You don't know what that person's normal blood pressure is. So even decreasing blood pressure to what you would still consider to be normal or even high could be hypotensive for that patient's brain, and that could be very bad. Okay. Identify what each of the following vital signs will do if there is enough pressure on the brain from a bleed from a stroke or traumatic brain injury. So it doesn't list doesn't list following vital signs, but I'm assuming they're probably talking about like pulse, respiratory rate, and blood pressure. So your pulse actually, initially, well, I guess we'll start with blood pressure. Your blood pressure is going to increase. And then your pulse initially will increase, and then it will have reflex bradycardia. So that's when you see that Cushing's sign, or whatever it's called. But it's actually less well known that your pulse initially will spike, and then it will tank, and your respirations will get irregular. They'll get irregular as the injury progresses, if there's signs of herniation and stuff like that, because of the compression on the brainstem. Since the only way to treat ICP in the hospital is to relieve pressure in the brain, what would be an appropriate action? So I'm assuming this means, I don't know if this means for the hospital or for EMS, but like in the hospital, common treatment is going to be like a hemicraniectomy. They basically make a hole in the skull to relieve pressure. They could place a shunt if it's some like kind of hydrocephalus problem, mannitol, 3% saline, depending on what's causing it. But also a nice little way to relieve pressure on the brain is actually to just elevate the head of the bed. That's a very low effort action you can take to relieve some, not a whole lot, but some ICP. By elevate the head of the bed by about 30 to 45 degrees. Identify some of the signs and symptoms of a stroke. I think we probably all know what these are. You just go down your FAST stroke scale algorithm, and in any of those findings, those are signs and symptoms of a stroke. Those are the signs and symptoms primarily of a large vessel occlusion. The signs and symptoms of a stroke that you have to be worried about missing are very subtle, like dizziness, vertigo, just weakness. Those can be posterior strokes they won't be caught under these kind of crude stroke scales, but they can still represent infarct or bleeding in the brain. Describe how each of the following strokes occur. So an embolic stroke. So an embolic stroke. This is an object in the vasculature. Usually it's a blood clot, but it can be other things too. That's kind of like quote unquote thrown from another part of the body through the cardiovascular system into the brain. A thrombotic stroke is different. This is normally also, this is a blood clot, but it's kind of one that develops in the cerebral arteries, and just slowly cuts off circulation over time. And then a hemorrhagic stroke, of course, is a bleed. Describe what occurs in a transient ischemic attack. So a TIA is so the word transient kind of means like it resolves over time. This is a stroke that resolves on its own without treatment. Um, Partial blockage of an artery can result in this. But so this kind of ties into the next question: identify a future problem that can occur as a result of TIAs. These TIAs are normally precursors to strokes. And identify the maximum amount of time that a TIA resolves from time of onset. So I think technically the limit is 24 hours, but I don't think I've ever encountered a patient that their TIA lasted that long. But yeah, I think that's the cutoff. Explain why patients experiencing a stroke or TIA should have oxygen administered via nasal cannula versus a non-rebreather mask. So this question's a little nebulous. I mean, if your patient requires oxygen administered via non-rebreather mask, then that's what you got to do. But we want to avoid giving too much oxygen to these stroke patients if we don't have to. And I think that's kind of what it's getting at. It's also that potentially stroke patients, we have airway concerns with them, and so like a non-rebreather mask, we don't really want to cover their mouth with stuff if we're not actively managing their airway. So, okay, explain what the symptom aphasia means. So this is lack of speech. This kind of prefix a means like lack of, like you think of asystole, there is no systole. Identify how you should manage a patient with aphasia and an open airway. So this is also a little nebulous because it depends on the patient and the situation. But if your patient has aphasia, they have potentially some paralysis of their vocal cords, which is to say that they can't protect, and could be paralysis of other structures in the larynx as well. So they could potentially not have the ability to protect from aspiration, so they may require airway management. Describe what each of the following symptoms mean. So dysphagia, this is dysphasia. This is difficulty speaking. Dysphagia, I often like say these words as the other one. This is difficulty swallowing. Hemiparesis, this is weakening of one side, and hemiplegia, this is paralysis of one side. Explain why it is important to place a patient with aphasia from stroke or TIA in the left lateral recumbent position. So this is, again, an aspiration precaution. Explain how each of the following postures from head injury or stroke will present and from what part of the brain. Okay, so they answered this question for us. So decerebrate posturing causes the extremities to extend and results from a lesion to the upper midbrain. Decorticate posturing occurs when the arms are flexed towards the core over the chest and results from a lesion at or above the midbrain. I believe the decorticate is a more sinister finding. Explain why airway is always the first thing that you manage, provided the patient did not go into cardiac arrest. So this is kind of a random question, but that seems like almost too obvious to even like put into words, but it's because you want to avoid hypoxia, and you don't want tissues to go unperfused, especially vital organs. So, and you need an airway to do that. So that's why we have A, B, and C. Describe each of the following types of syncope. So cardiovascular syncope, this is a loss of consciousness from a problem that results in that stems from the heart. So it could be an arrhythmia, could be some mechanical problem. but the heart caused there to be a lack of blood flow to the brain, like VTAC, for example. There are any number of other things. Hypovolemia. So this is kind of like what you would think about in a dehydrated patient. They were going to have positive orthostatic vitals. So they're laying down, they're fine, but then they sit up or stand up and they might pass out or have near syncope. And if you took their blood pressure standing up, it would be a lot lower, or their pulse would be a lot higher to compensate. And then non cardiovascular, this is just all other medical causes of syncope. And then idiopathic is unknown. So non cardiovascular, this is like you know the cause, but it's not cardiovascular and it's not hypovolemia. And idiopathic is you don't know the cause, but it could potentially be those things. You just don't know. Identify the one drug that should always be considered in a patient with altered LOC or respiratory depression. This is going to be naloxone, the key word there being respiratory depression. Define each of the following conditions that can occur in the brain. Neoplasm. So a neoplasm is a new growth of a tumor, so that doesn't include tumors that are present at birth. And you can get those, I mean, this is just kind of the word for a new tumor that grows in your body. So you can obviously get those in your brain and central and peripheral nervous system. And an abscess, this is usually from some kind of like local infection. This is a collection of pus. Identify why dexamethasone would be beneficial in treating a brain abscess. So dexamethasone works by, well, it doesn't necessarily work by this mechanism, but it has the effect of reducing vascular permeability. So it's going to stop the creation of more cerebral edema around that abscess from the inflammatory response, and could potentially also prevent that pus from being circulated. But I think that would be more of a like secondary consideration. Identify common symptoms of meningitis. So the common symptoms of meningitis is going to be like a headache. You probably a throbbing headache in the back of your head usually, fever, and then not necessarily altered mental status, but maybe confusion or like slow responsiveness depending on the progression of it, and then neck stiffness or nuchal rigidity is sometimes called. That's a very common like hallmark sign of meningitis. Okay. Describe following diseases of the brain. Alzheimer's disease. So Alzheimer's, this is the most common cause of dementia. That's a very high yield piece of information. So Alzheimer's is the progressive atrophying. So it's getting worse of the cerebral cortex. So this is going to lead to initially short-term memory loss, but then it'll progress to long-term memory loss, and then eventually some psychosis, essentially, and a myriad of other problems. But it's important to know that Alzheimer's is the most common cause of dementia. Parkinson's disease, this is kind of an idiopathic degeneration of dopaminergic neurons in the midbrain. Yeah. So ALS, this is the selective destruction of motor neurons, which eventually leads to the kind of weakening and paralysis of the diaphragm and respiratory muscles. And people diagnosed with ALS are often die within 5 years of this diagnosis. Okay. Bell's palsy. So Bell's palsy, this is a sudden onset usually of one-sided, so unilateral facial weakness or paralysis. And this is caused by some kind of damage or insult to the seventh cranial nerve, which is the facial nerve. And when this happens to people, they think it's a stroke because it can look like a stroke, except that all of the symptoms and the neurologic findings will be in the face. And one way you can tell this apart from a stroke is assessing the patient's forehead and eyebrows. So in a stroke, the forehead muscles are spared because they are also kind of innervated from a different part of the brain. But in Bell's palsy, they will be more often than not paralyzed. So that's a very quick way to determine to rule in stroke versus Bell's palsy in these patients. Okay, so multiple sclerosis. So this is the destruction of the myelin sheath. That kind of, it's like a fatty sheath that wraps the nerves, and that when it's destroyed, it affects the ability of those nerves to pass impulses down the axons. Which, I mean, as you can imagine, that's less than ideal. So muscular dystrophy, this is, there's lots of different kinds of muscular dystrophy, but normally this is the progressive destruction of skeletal muscle. Usually it does not affect smooth and cardiac muscle, but I think there are some like more rare versions that do. Okay. Myasthenia gravis. So this is an autoimmune disease. The body has kind of convinced itself to attack the neuromuscular junction. So that's where the neuron kind of innervates the muscle and tells it what to do. So in myasthenia gravis, the immune system will attack that junction, and specifically, normally the acetylcholine receptors at the junction. And it'll destroy some of those receptors and make it hard for the nerve to pass the neurotransmitters onto the junction. Explain why a patient with diabetes would have warm, dry skin and deep, rapid respirations. So this is a very random question here in this part of the thing, but this is classic signs of DKA. Describe the following types of headaches. Cluster headaches. So these are more common in men, and they're kind of like a series of small, intense headaches from a few minutes to an hour or so, and they're usually on one side of the head. Migraine headaches, these are more common in women, and these are very long, prolonged headaches that can be very intense, and they're usually on one side of the head as well. Tension headache, this is the very like common form of headache that we all have all the time, and this is just characterized by kind of a dull pain. It can be in your head or in your neck too. And then the distinction of organic headache, this just means that the cause of the headache is some organic process like an infection or a tumor. Describe the pulse oximeter and how it works. So pulse oximeter works actually, it's pretty cool. It shoots two beams of red light into the tissue, and one of those like frequencies, wavelengths of light, is absorbed very easily by hemoglobin that has oxygen, and one of those is absorbed very easily by hemoglobin that does not have oxygen. So it shoots both of those in, and it measures which one gets absorbed more, and it looks at the ratio, and then that's how it determines how much of your blood in that area is oxygenated. Explain when you would use a non-breather mask versus using a nasal cannula. So this is just if your patient needs more oxygen. Identify some of the benefits of administering Atrovent to a patient with emphysema. So this is going to, Atrovent is going to be useful in these patients as well as other patients to kind of dry up secretions and it also it works on a different pathway compared to, for example, like beta agonists to dilate the smooth muscle around the airways. Um, so I'm a big fan of Atrovent use in these patients and in other patients because it it doesn't just hit the same pathway over and over again. And these patients usually have, like some kind of inhaled beta 2 agonist that they've just been using repeatedly for days on end. And Atrovent works on a different pathway, so it's not just kind of beating a dead horse. Um, so identify some common signs and symptoms of lung cancer. So really common signs and symptoms of lung cancer is like a persistent cough, and then coughing up blood, obviously shortness of breath and things like that. Describe what effect a metered dose inhaler would have on the heart. So a metered dose inhaler, um, this is going to kind of tie into the next question, identify and list the properties of beta 1 and beta 2, but it's going to increase the heart rate, positive inotropy, positive chronotropy, um, make the heart beat faster and harder. Identify and list the properties of beta 1 and beta 2. So beta 1 primarily works on the heart. And these receptors are specifically in the SA and AV node. So when they're stimulated, they're going to increase the inotropy and chronotropy and dromotropy as well. And then there's also beta 1 receptors in the kidneys that increase renin secretion. And beta 2, these are more commonly found in smooth muscle around the lungs and airways. And when these are stimulated, they're going to dilate and relax the smooth muscle. Explain why assessing lung sounds is so important when a patient has JVD. This is going to tell you if the patient has pulmonary edema associated with that. Could be looking at a patient with left heart strain. It's going to rule that out, rule that in. Yeah. Explain why assessing lung sounds first in a patient with respiratory distress is of such importance. So this is important because it kind of tells you what treatment pathway you're going to go down right away. So you have a patient with respiratory distress, you listen to their lung sounds, they're wheezing. Okay, you know this is some kind of obstructive disease. That can kind of guide your history taking and what medications you want to give right away. Identify the function of albuterol, also known as Proventil, a beta 2 agonist in treating COPD and asthma. So albuterol is a hallmark treatment of COPD and asthma because it provides very fast relief of the bronchospasm by stimulating the beta 2 receptors in those smooth muscles. Identify the purpose of surfactant in the lungs. That is to keep the alveolar sacs open so that they do not collapse. Explain what would happen to surfactant in drowning and what this would cause. So surfactant is damaged, destroyed, etc. in drowning, and this results in really poor surface area for ventilation to take place. Explain what asthma is and its effects. So asthma is a very chronic condition from inflammation of the airways that causes them to narrow and have bronchospasm, resulting in shortness of breath. Explain Cushing's disease and its effects. So Cushing's is the overproduction of cortisol in the body. You want to think about kind of the moon face. It causes a lot of weight gain. The buffalo hump as well. This can cause a lot of fatigue. It can also cause hyperglycemia. Okay. Identify the best position to transport a patient that is experiencing respiratory distress. So aside from like whatever position they're comfortable in, they're going to want to sit these people up more often than not. Describe each of the following lung diseases. So pneumonia, this is going to be the result of some kind of infection in the lungs. Could be from aspiration, could be from any number of things, and it's going to cause just a whole lot of gunk essentially down in the airways. That's going to decrease the surface area for ventilation and cause respiratory distress potentially. Lung cancer, so this is obviously going to be some tumor growth in the lungs that could obstruct the airway, or it could affect the alveolar tissue themselves, depending on where it is. Myasthenia gravis, we already talked about this. This is when the body creates those antibodies that attack the neuromuscular junction. And then acute respiratory distress syndrome. This is essentially pulmonary edema that's not from cardiogenic cause. It can be from any number of causes. Could be from sepsis, a lot of things. But it's accumulation of fluid in the interstitial space in the lungs. And then pulmonary embolism. This is a blockage in the pulmonary arteries. So this is going to the ventilation, the oxygen reaching the lungs is not the problem. It's the oxygen reaching the blood from the lung tissue that's the problem, because there's a decrease in blood flow. Explain who is most likely to get a pulmonary embolism. So pulmonary embolisms are common in sedentary lifestyles, obese patients, people with DVTs. Also a huge risk factor that's pretty high yield. We've talked about it before, but is female patients taking oral contraceptive. Identify which type of medication in addition to antibiotics is used to treat ARDS. So when you think of pulmonary edema, you might think of like a diuretic or a nitrate, but these are not useful in ARDS because it's not cardiac in origin, but sometimes a corticosteroid will be used in ARDS to reduce that vascular permeability. Explain what you would do if you could not hear lung sounds due to excessive noise at the scene. So you're just going to have to reassess that later if it's not a possibility at that time. Explain why you should always have suction readily available when preparing to intubate a patient. Intubating a patient is it's a vulnerable time for that patient's airway, and you need to make sure that they don't aspirate. If the patient vomits or there's secretions in their airway when you're going to intubate, that can affect your view and slow down the whole process. But if you have suction ready to go, it can go smooth. Identify some of the signs and symptoms of pneumonia. So patients with pneumonia, they're usually going to report other symptoms of kind of just feeling ill or sick. Productive cough might be yellow or brown or another color. Might have some chest pain, usually going to be kind of pleuritic chest pain.